Society Matters.
Hello, and thank you for joining us today. I'm your host, Dr. Susanne Seperson, and this is our 8th episode of the podcast, Antisemitism and the United Nations and in Society, on HMTV. It is my pleasure to introduce our guest, Dr. Barron H. Lerner. Dr. Lerner is a medical doctor and historian who holds 2 faculty positions at the New York University Grossman School of Medicine. He's a professor in the Department of Medicine as well as in the Department of Population Health. He's also a noted author, historian, and bioethicist, as well as a practicing physician. He's published 5 books on diverse topics, including an award-winning book on breast cancer, drunk driving, controlling tuberculosis, illness and celebrity, and The Good Doctor, a father, a son, and the evolution of medical ethics. He's written numerous articles for professional journals, as well as the New York Times, Washington Post, Slate, and appears on TV and radio. We are honored to have him join us. So welcome, Dr. Lerner. Let's start with some questions about your background. Could you tell us a little bit about yourself, your background, and where you grew up?
Well, I actually grew up in the house that I'm sitting in now, amazingly. In the 1960s, my parents relocated to Cleveland, which is where my dad had grown up. So I was, I think, going into first grade in the mid-1960s and went through high school here. And my mother, amazingly, is still in the same house after all this time. My dad was a physician. So he had done his training in Boston in infectious diseases, and then the family moved back here, and he became a faculty member at Case Western Reserve School of Medicine. And he was a very well-regarded physician in Cleveland, worked at a hospital predominantly called Mount Sinai Hospital, which catered not exclusively by any means to Jewish patients, but a lot of Jewish patients. And he very much wanted me to follow in his footsteps and become a doctor, which I did. Even amazingly bringing me on rounds when I was like a little kid and putting me in a white coat. So I guess that's sort of coercion in retrospect, but I'm glad he did it, certainly.
Well, as a sociologist, I would say pre-socialization. However, did you have other family members in the medical field?
Well, my dad was the first doctor in the family by far. His father had been a furrier, working class, and his grandfather, who also I knew and lived in Cleveland, ran gas stations. So for my dad, was really the first one in that wing of the family, not only become a doctor, but to go to college. But his younger brother, Alan, was also a physician. My dad was an infectious disease doctor, and Alan practiced at the same hospital and was a radiologist. So both of them were, in a sense, role models for me.
So your grandparents must have been very, very proud. But now, at what point in your career did you decide to focus on medical ethics? And particularly, how did you become interested in the history of medicine?
Well, I'll answer the history part first. History was always my favorite topic in school when I was in elementary school and high school. And when I went to college, I decided, in addition to taking pre-med classes, I would also be a history major, which at the time the pre-med advisor didn't like. She thought it was a bad idea, that I didn't look serious enough to be a doctor, but she was wrong, basically, because now it's not uncommon to do that sort of thing, and sometimes perhaps even strategic to be a broad-based applicant. And so I was not only a history major in college, but then when I went to medical school, fortunately, the professor that they had just hired to teach the first bioethics class in medical school, at my medical school, was actually a historian of medicine. So I very much sort of glommed onto him and did research projects with him and hung around and really started to love the history of medicine, even as I was learning how to become a practicing doctor. Following both of those pathways was really productive.
Dr. Lerner, this is Bernie Furshpan here. I'm the co-pilot today, and thank you so much for joining us. I also, as an undergrad at Stony Brook University, I was a pre-med student. Many disciplines intersect. I was a pre-med student, but my advisor told me it wasn't such a good idea for me to minor in graphic design. And so, but I insisted that I continue because I love to draw and I love to put things together. And I became the cartoonist for the magazine and the newspaper at Stony Brook University. As a result, I actually ended up in chiropractic school and I created a whole marketing line of material for the chiropractic profession with posters and graphics that really help elevate the standards of the marketing campaign that we did at the time. So I commend you, and I have a similar story in that I had interest in graphic design and it really did pay off in the long run.
So both of you are excellent examples of the value of a broad liberal arts education.
And look what I've done here at the Holocaust Memorial and Tolerance Center. I've incorporated those skill sets in upgrading the quality of the marketing and the graphics that we use here.
Okay, so we move on now to medical school education. It's my understanding that medical school students and graduates are taught the Hippocratic Oath, which basically is do no harm. And I want to begin by pointing out that most doctors do no harm. In fact, they do a great deal of good. But yet, when we look at our history, we know that there are doctors who have done enormous harm. So, for example, during the Holocaust, we had the evil Dr. Joseph Mengele, referred to as the Angel of Death, who performed horrific experiments on Holocaust children who were incarcerated in the Auschwitz concentration camp. And he did these horrible experiments, especially on twins. So do you think Mengele was unique, or did other doctors also commit acts of sadistic barbarism in the name of science?
Unfortunately, Mengele is not unique. So there's now a very extensive literature on Nazi experimentation in particular. So among the things that this is certainly one of the topics that I initially sort of studied as a graduate student and then later have written about. One of the most distressing statistics I ever heard was that of all the professions in Nazi Germany, physicians had the highest membership in the Nazi Party. And then there's many stories that some of us have heard about what happened to physicians, Jewish physicians and other Jewish people in the health professions, obviously, even before the actual Holocaust, where their jobs were taken away. And so it's a very awful chapter in the history of medicine, and the writing about it has been very good. Among the first people to write about it was Robert Lifton, who recently died. I mentioned him, the noted psychiatrist who wrote about this and talked about that exact issue. How could it be that a profession that was devoted to do no harm, that took the Hippocratic Oath, could go 180 degrees? And many people have written about this, and the punchline, I guess, is the service to the state. The Nazi state overwhelmed their humanistic and doctor-like instincts. But it remains a very important cautionary tale for all physicians, and not just in horrific circumstances, but the importance of keeping your patient front and center, your research subject front and center, and not violating their rights remains crucial.
So what you're saying is they put their allegiance to the state above their allegiance to the moral practices to their God, if you will. And they replaced, if you have a belief in God, their belief in God with a belief in the state. But I really do not understand. Personally, I was born in Germany. My parents were Holocaust survivors. I find it very hard to believe that Nazism, in fact, began in Germany, which was a relatively educated and prosperous country. So why do you think the medical doctors and university professors in particular supported the ideology and politics of Nazism?
The what they would say to you is that what they were doing was trying to ensure the health of the state. So what was first thing, they were not interested in the health of Jewish people or other minorities who were tortured and victimized in the Holocaust. But they felt that for the rest of the population, the health of the state was important. So in a great irony, if you look at some of what Nazi medicine advocated, it would look remarkably similar to today, where eating a healthy diet and getting screened for cancer, things like that were being advocated. And somehow the doctors made the leap from saying that it was okay to discriminate and eventually torture certain members of society to try to ensure that the rest of society, the desirable people, the master race people, got better and better health care.
Well, that brings me to other cases, including American doctors who also, in my opinion, committed medical atrocities against vulnerable people. For example, there's the infamous Tuskegee syphilis study conducted by the U.S. Public Health Service, and it ran for 40 years, from 1932 until 1972. The study was supposedly designed to observe the natural history, the course of untreated syphilis, and the subject were poor Black men. Of course, informed consent was not given, and after it was known in 1945 that penicillin could be used to treat syphilis, it was not given to them. It was only ended in 1972 following a leak by a whistleblower to a publication. And so why do you think the study continued for so many years after many men suffered and died, as did their female partners, through sexual transmission?
There's a lot in there. Lots of reasons, I think. It did go 40 years. One major reason, obvious reason, would be racism. So if we just got finished talking about how the Germans viewed the Jews as an inferior race, the people who worked on this project in some ways viewed Black people as an inferior race who it was okay to experiment on, even if it meant they were going to die. So that's certainly a major reason. But there's other reasons also. The doctors running the public health service were ambitious doctors who thought that if you studied these diseases, and by the way, it wasn't entirely malevolent. When Tuskegee study started, the funding was from a very reputable philanthropic organization, the Julius Rosenwald Fund, and they genuinely wanted to know. They thought syphilis was a different disease in Blacks. So why don't we study it? There's not really good accessible treatments for Black people. Why don't we try to learn about this? But as you point out, once penicillin became available, the Black men in the study were aggressively deterred from learning about what they had actually and getting any kind of treatment, which brings us back to the racism argument. I'll just mention one other thing, because a very smart historian also has written about this. It's not the sexiest explanation, but I think it's part of it. And what he came up with was inertia, that the study had been going for so many years, and the public health service people basically just kept checking a box every year, and nobody revisited what the ethical transgressions were, even though, as we now know, periodically at least, physicians and other people were contacting the public health service in very impassioned terms, arguing that what was going on was unethical.
Thank you. And, it reminds me, be careful when you point fingers, because make sure that your own house is pristine as well. So now I'd like to turn to the book you wrote, a very personal story about your father and you, and the way each of you practiced medicine. Is called The Good Doctor, A Father, a Son, and the Evolution of Medical Ethics. Can you tell us about the book and the different ways each of you treat or treated your patients, and how you personally dealt with your feelings about your father?
That book is obviously biographical and autobiographical. My other first four were not, but you reach a certain point and you feel like you've practiced medicine for long enough, you've been a historian for long enough, that maybe you have some insights in matters like this, matters of sort of the past of medicine and the future of medicine. But what specifically interested me with respect to my dad was that I had been brought up in a household where my father was revered as a physician. I can't tell you the number of times I heard stories from patients and other members of the Jewish community in Cleveland about how my dad had saved their lives, and how attentive he was and what a great doctor he was. So that was sort of always in the background for me. But my dad was also an extraordinarily paternalistic doctor. So in the years I'm talking about, which is he got his medical degree in the 1950s. So from the 50s, certainly until the 1970s, it's what we might call the heyday of paternalism in medicine. Doctor knows best, Marcus Welby, let the doctors make all the decisions. Don't worry. You don't need to know everything. You don't necessarily need to know you have cancer. Just let me treat you. And then I get to medical school, and the P word, the paternalism, is like the worst word you can use all of a sudden, because the world was changing. And you mentioned Tuskegee. We talked about that, which was a big part of it, because the criticism of the medical profession that followed Tuskegee was that doctors thought they were above ethics, and that doctors could make bad decisions, and maybe you needed other people to monitor the doctors and make sure they were doing the right thing, and those people became the bioethicists. So when I took my bioethics course in the first year of medical school, that was the mantra. Paternalism was bad, and it was getting replaced by what we would call autonomy, or patients' rights, that the patient should be the primary decision maker, and concurrent with that had to be meaningful, informed consent. So, and you mentioned informed consent before, that was what absolutely was missing at Tuskegee and in all the other human experimentation scandals. So you needed both when you're doing experiments, but also when seeing patients. Patients needed to know all their options, all their choices, and the doctor's job was not to make the decisions for them, but help them make the decisions that they wanted to make.
I appreciate what you're saying, and I'm well aware that medicine is practiced differently today. However, the doctor does have so much more experience with the particular kind of disease that you're dealing with. So isn't it natural for a patient, or I will just describe my mother's situation, who passed 2 months before her 98th birthday, and at 97 and a half, she received a pacemaker. I would turn to then they asked me, do you want to do it? It's not going to prolong her life, et cetera, et cetera. And I said, how do I know? In fact, I said, ask her, because her mind was clear. Her body was failing, but her mind was very clear. And I kept saying, well, what would you do if this was your mother? And my feeling was, you've seen so many more cases. This is my first case. So how do you respond to that when the patient says, well, what would you do?
Even though the pendulum swung from paternalism to autonomy, it never really swung all the way there. And by the way, just to reiterate, the tension in the book was between my father being seen as such a good doctor for being a paternalist, and me trying to be as good a doctor favoring autonomy. That's the tension that permeates the book. But I think most people practicing medicine would say that autonomy does not necessarily represent the best choice all the time. I think it's still the default option that one should engage their patients and or their patients' families in ways to try to get them to make the decisions. But absolutely, there's situations where either the question is ridiculous, it's just too detailed, or that the patient and family genuinely wants opinions about what the doctor thinks, which harkens back to that old paternalism in interesting ways. So to me, the art of being a good doctor is balancing those two tendencies and knowing which patients really want to be the decision makers and knowing which ones would prefer more assistance.
So there's a sense of communication is the real issue, and knowing your patient and so on. So if you would, or if you could, how did this impact your relationship with your father?
It's an interesting question. So he very much knew I was writing the book. The book, by the way, starts out, I started out with the big story of the book. And I don't have time to go into all the details, but the short version is, in 1996, a patient who my father was following, who was end stage and in agony, but was do not resuscitate, died on rounds one morning. And the legal and ethical thing to do would have been to call a code and try to resuscitate her. But my father, who knew her best and believed he knew best, physically prevented the team from doing it. He put his body over the patient and wouldn't let them near her. And that's the story I start the book with. And I say in the book, as someone who was studying bioethics, he would get an F, right? I mean, he was like the test case of why you needed people from the outside monitoring doctors, because he was playing God, one would say. But my dad knew what I was up to, that I was going to be taking him on in the book and challenging some of his precepts. But as you might imagine, as the book goes on, because nothing is ever absolute, I grew to understand more and more about why my dad did what he did and why he thought it was justifiable. So we had some pushback and give and take, but he understood, certainly by the end of his career, that he had to do a lot more asking of patients. And I also knew that even in my respect for autonomy, that some of the type of medicine that he practiced, which was so paternalistic and doctor-centered, still had a place.
So I just want to share with you that when I was called into the hospital for my mother, who was on all sorts of tubes and machines, which she expressly said, do not resuscitate. I want no machines, but none of that happened. And they called me in and they said, well, we're going to pull the plug now. And they pulled the curtains around and I said, can I stay? And they pulled, the tubes out and so on, and they expected her to expire. And we sat there and we sat there and we sat there, and she opened up her eyes and she said, what are you doing here? And she lived another 6 months. So,
wow.
Yeah. So there's a will to live, and yes. We know a lot, but we don't know everything. So I'd like to turn now to current medical education. I know there's much more of a focus on ethics and the treatment of patients, but are you aware of how much education about medical ethics students are currently required to have or do have?
It depends on what school you go to and what they put in the curriculum. So some schools prioritize it based either on their philosophy or the faculty that's there, and at other places you sort of have to kick and fight to get it into the curriculum. Part of it, but having said this, things are so much better in general than they were when I was in medical school, and this was just seen as some kind of an outlier topic. Really, I'll just give you another example. We used to teach at NYU, we used to teach ethics in the end of the second year for the students. And we developed our curriculum, and among the things we talked about was Tuskegee and racism in medicine and things like that. And at some point we realized that we were getting all these bad reviews. And among them was like, we already learned all this. And we realized that other people in the curriculum, through various types of courses or initiatives, we're already teaching things like Tuskegee and Henrietta Lacks and other stories, which was sort of embarrassing for us because we didn't really know that and we had to rejigger things. But it also, I think, spoke to the fact that you really can't practice medicine or teach medicine these days without a careful consideration of things like gender and race and ableism and things like that. So in that sense, I think things are better.
Which brings me to the current state of affairs with the alarming rise of anti-Semitism in the United States, throughout the world. And as a retired academic myself, I know that it is now infested, anti-Semitism infested in the curriculum and the practice of social work, psychology, history, many fields. And I was wondering if you were aware of how much anti-Semitism there is in the medical schools in terms of admission practices, in terms of treatment of medical students, and treatment of Jewish patients.
It's interesting. I maybe I'm in a bubble, but I have to say, in my neck of the woods, I really haven't experienced any of that or really heard about that. But I've heard about this at other places, and I've read some papers, for example, peer reviewing papers that talk about these issues. And I think it needs to be taken very seriously. I think that some of the more prominent examples of this have not occurred at medical schools as much, I think, as undergraduate campuses. I think that's where I think a lot of the as I understand, a lot of the active protesting has been, and these issues are more front and center. But just to make sort of obvious points about what we've been talking about, whoever the discriminated group is, it's unacceptable. And in a practice of medicine, the importance of respecting people's rights, of getting consent, of treating people decently and in an ethical way, whether they're your colleague or whether they're patients or people working at an institution, is crucial. And I think history can be very, very important here, because even as you alluded to before, it was sort of surprised that Germany became the place where physicians proved to be so anti-Semitic. So if you study history, you understand that people in history make choices, and the ramifications of their choices are important, just like the ramifications of choices today are equally important.
I thank you for that, but I do want you to know that the anti-Semitism at the doctoral level in the fields that I mentioned is rampant, is serious, but we don't have time to go into that. So before we close, I'd just like to ask you, what do you think is the one most important thing that you'd like our audience to take away from today's discussion?
Well, I'll put another plug in for history. I think what drew me initially to history, and I think makes it so valuable, is what I said before, which is to the challenge of not looking back from our current perspective and judging, but trying to put yourself in the shoes of historical figures and understand the factors, some of which we've discussed today, that made them do what they did, whether they were Nazi physicians or whether they were running the Tuskegee study. What was it that made people, certainly in the Tuskegee study, who were well-respected public health officials, what made them willing and able to continue to work on a study that, by all accounts, was blatantly racist? Well, if you read books about this, you learn that there were complicated issues and complicated things that went on in their lives, and the institutional structures and money and grants. And those types of temptations and complications remain today. So, that's why I'm always plugging for us to go back and with avoid the hubris of saying, you know what, we're not like them. We would never make the same mistakes they did. That's the wrong way. What you really want to do is say, what was it that made those behaviors so prominent at that time, and realize that 50 years from now, or whenever, people will be looking back at our decisions and judging us as well.
Well, I want to thank you very much for your presentation, your discussion, your wisdom. And I want to thank the audience for tuning into this episode of Anti-Semitism in the United Nations and in Society on HMTV. I appreciate my guest, Dr. Barron Lerner, my co-host, Dr. Bernie Furshpan, for sharing his experience and perspective on ethics in medicine and in society. I know you will want to continue to share your insights with us, and I look forward to your next book. Be sure to subscribe, share, and stay connected for more engaging conversations. Until next time, make it our time. Take care and be well.